Good morning, everybody. Today is May the 20th, 2023. We're excited and welcome everyone to come and join us for our second session, which is Neonatal Sepsis. We have our esteemed doctors here. They prepare something for us to learn. And this is going to be a continuation of training when we go to the medical mission. So we do have Dr. Msambichaka, Dr. Ngiri, and Dr. Mkoni with us, and I'm going to let them take over and start this discussion. Thank you, everybody, for coming.
Thank you. Can everyone hear me?
Yes.
Yes.
Yeah. So my name is Fabian Guido. I'm a peds hospitalist. Of course, I'm Tanzanian native. And then together, Dr. Msambichaka and Dr. Mkoni will be presenting this. Dr. Mkoni has something going on. She's not sure if she'll be able to make in time, but Dr. Msambichaka and I will cover pretty much the whole topic. And our goal is to get everything wrapped up within an hour. And then if there are further questions and discussion, then we'll continue from there. We have no financial disclosure. And our objectives for today's talk, we're going to look at the global facts on child mortality. And then our main focus is going to be neonatal sepsis, management of suspected of confirmed infection. And then follow up this, at some point we'll have a talk about pediatric sepsis. So today is just neonatal sepsis. And then the other objective we'll be looking is prevention of infection in neonates. So according to WHO, there's a big difference in chances of survival depending where you're born. About 5 million babies under the age of 5 usually die every year, and about 2.1 million between age 5 and 24. So in 2021, there were about 2.3 million children who died in their first month of life. So that equals to about 6,400 babies who are dying every single day. So it counts about 50% of all the children under the age of 5. Again, in the same year, according to WHO, for mortality for children who are under the age of 5, global wise was about 38 deaths per 1,000, while in low income country is about 67 deaths per 1,000 live birth, compared to high income countries only 5 per 1,000 live birth. The leading cause of preventable death for children who are under the age of 5, it's prematurity and birth complication. That's why we mentioned about 50% of all those children die before the age of 1 month. Other causes being acute respiratory infection like pneumonia, diarrhea, and malaria. So the main causes of under 5 death are communicable and infectious disease. That's our talk today. We're going to focus on neonatal sepsis. For children who are age 5 to 24, then injuries being the leading cause of mortality. So the big issue when you see a child who is sick is to try to differentiate. If the parent bring a child, your first step is just to look at the child, do your assessment, and decide who is sick and who is not. So looking at the 2 pictures, so parent brought one, the one on the left side who got the finger prick. So look at her, she's alert, she's smiling. I mean, she might have a fever, but the chances of serious infection is extremely low. Whereas if someone shows up, they're in a waiting room, they might have a fever or not, but just looking at the child on the right side, you can tell right away the child does not feel well. So child like that, if it's a triage, then they should get the priority, get the workup done, try to find out what's the cause. So the big thing is to be able to tell who is sick and who is not, and then go from there. I mean, sometimes they're freaky, they might look well, and then within an hour, it's a different baby, but for the most part, if they walk out the door, you should know like, okay, I need to jump or not. So neonatal sepsis, we usually call sepsis like for all kinds of infection, but definition requires to have bacteremia, like bloodstream infection. So for neonatal, it's less than 28 days, but for our talk, we'll focus up to age 60 days, so 2 months of life. It's a leading cause of morbidity and mortality among infants, especially in middle and low income countries. High risk infants are those who are born premature and low birth weight. So usually we send the blood cultures, but it's only about 3 to 8% of the cultures stand positive. And this is because when mom is in labor and they have risk factors like prolonged rupture of membrane, or they have fever, or they are screened, they tested positive for bacteria. So usually most places will give mom antibiotics. In that case, it might sterilize some of the babies who come out. So their blood culture will end up being negative, but truly probably they had bacteremia. And then depending how much blood you're collecting, so recommended at least 1 ml of blood. So sometimes with the difficult getting blood, we might send half a milliliters of blood. In that case, it might not necessarily turn out positive. So there are two definitions for sepsis, early onset and late onset. So early onset sepsis, the one occurs before 7 days of life. In the past, they used to say 3 days, but now even WHO, it goes with 7 days. And this is mostly vertical transmission. The pathogen from female genitourinary system goes to the newborn during labor or delivery and cause infection. In United States, the most common cause for early onset sepsis in babies is group strep infection, GBS. Also, E. coli is also rising, and then of course we have coag-negative staph. Risk factors for early onset, it's chorioamnionitis. If mom was screened and tested had positive GBS, colonization, infants who are born premature, and then if there's a prolonged rupture of membrane greater than 18 hours. For late onset, it's usually after 7 days of life. We call it lateral transmission. So the pathogen is from the environment. So from contact with the healthcare, so emphasis about hand washing, instrument we use in the nursery, hand hygiene or general hygiene for parents when they go home. So important thing is just to prevent infection that way. And we'll talk that at the end of the talk. So in rare situation, the baby might have contracted infection during labor and start showing symptoms after a week, but it's rare. Most of the time, it's something happened after the baby was born. Again, risk factors being born premature, intravascular catheter insertion. That's why we try to minimize IV insertion if necessary. So if you have babies who need a blood sugar, if there's a way to avoid putting IV, it's better. And then if the ones who have central line, of course, need be careful with maintaining sterility. And then for late onset, most of the time the cause is coag-negative staph. So this the slide at the reported in Tanzania. So also early onset within the first week, risk factors, prematurity, prolonged rupture of membrane, choreo, maternal fever, and then maternal bacteriuria. So if mom had bacteria during pregnancy, because that bacteria is increased risk for getting infant sick. The most common cause, even in Tanzania, so group strep, E. coli, Listeria, and others like Haemophilus influenza and Klebsiella. So in Tanzania, they do not routinely test for GBS, but according to Majigo et al., about 21% prevalence of GBS, which in US is 25%. So for the ones who get tested in Tanzania, also GBS is at the top. And for the late onset, just as we talked before, risk factors being premature, infants, hospitalization, umbilical catheter, catheterization, intubation, babies on mechanical ventilation, and then congenital anomalies. The most common cause is Staph aureus, Haemophilus, and Klebsiella. So management for suspected or confirmed infection, empirical antibiotics, CRE. We recommend within 1 to 2 hours, the infant should be receiving antibiotics if you suspect they have bacterial infection. And sometimes we focus so much on getting testing done and this and that, so that delays the treatment. So important thing, do not delay treatment. If you have difficulty getting labs, it's better giving baby antibiotics and then worry about the labs later. Treatment should be based on the treatment guidelines. So United States, we have guidelines, and in Tanzania, there are guidelines. We'll send the link for people who do not have the guidelines on what antibiotics to use. But the first line worldwide, it's usually ampicillin and gentamicin. They cover most of the pathogens. So down here, it's some of the antibiotics and the doses we use depending on your gestational age, and then age, how old you are since birth. Dr. Msambichaka is next.
Hi, I'm gonna need some assistance on advancing the slides, but so thank you, Dr. Guido. I just wanted to kind of follow up on what Dr. Guido talked about. He's described what early onset sepsis is, he's described what late onset sepsis, and the guidelines for treatment. And it was truly interesting to see that the guidelines, the US guidelines and the Tanzanian guidelines are very similar. So what we're gonna try and do in the next few slides is just kind of take the guidelines as they are, but then use an algorithm to try and determine how do you go about, when you encounter a baby that you suspect is sick, or a baby that's kind of like in the gray zone, or a baby that might look well. And so I would encourage anybody that is, not from the US that's listening in to please, share your input, because that is what this is all about. So let's talk about this case. This is pretty typical on the neonatal unit. You are asked to evaluate a 24-hour-old baby boy for poor feeding. This is a baby that was born at 37 weeks gestation, the first-time mom, 26 years old. The mother received routine prenatal care. Her pregnancy was not complicated. She came in, she was ruptured for 30 hours, clear fluid. And then intrapartum, there was suspicion by the obstetricians that she had choreo, so she appropriately received antibiotics. We have a healthy newborn, born at, through spontaneous vaginal delivery. APGARs were 8 and 9, and it was an appropriate for gestational age infant. And the mom, is breastfeeding. So just based on this information, if you are, whether you're a nurse or a healthcare worker in Tanzania, what would you do, or what questions would you ask further to evaluate this infant? So if we think about the classification, the first question to ask is, how old is this baby? Obviously, it's 24 hours. And the first question is, the first thing you have to do is, obviously, you ask more questions. Hopefully, you ask about vitals. You ask about how feeding is going, what's defined as poor. As we know, feeding can be a very non-specific thing in newborns, especially in the first 24 hours. However, you want to look at the risk factors for sepsis. Was there maternal fever? Was there choreo? Was the rupture of membranes prolonged? What was the gestational age of the baby? Was there fetal distress during labor? All those are risk factors to consider. And then the next question you ask yourself is, does the baby look sick? so if you remember the two pictures that Dr. Guido showed, does the baby have distress? Is the baby apneic? Is there lethargy? You know, are they feeding poorly? Fever, hypothermia? In the first 24 hours, sometimes it might just be hypothermia and not necessarily fever. Do they look like they're in shock? Poor perfusion? Do they have a seizure? Do they, you know, look altered? If the answer to this is yes, that is, you know, you have to act immediately and do not delay care. If the answer is no, then this is usually, most of the babies might fall under this category where, yes, they have risk factors, but on your exam, they don't look so bad, or they're poorly feeding, but that's kind of not abnormal in the first 24 hours. But that infant should still be on high alert because they do have risk factors. So in this case, you would do serial exams with vitals every 4 hours, and make sure you observe this child in the healthcare facility. This is not a child that you're discharging at, you know, 24 hours, because we know, like, early onset sepsis, always talked about, you know, it's usually the first 7 days, but usually if it's going to present itself and it was vertical transmission within the first 36 to 48 hours, that is when you will catch it. So keep them in the facility if you can. If you can extend more than 48 hours for other reasons, depending on where you're practicing, do that and observe this child before you send them home. If they are sick looking, if they have risk factors or they have any of these characteristics, then you should, if you're able to, you know, understanding the limitations of where you're practicing, you know, get a blood culture, get a CBC. If you're able to get a CRP, you can get it. We understand that not every facility has this. And by all means, do not delay antibiotics. They are life-saving. You can figure out the labs and everything else, but do not delay antibiotics. And as recommended, these are the initial antibiotics. And so this is just a graphic presentation. You ask yourself risk factors, are they sick or not sick? If they're sick, you know, antibiotics, transfer care if you can, start the workup. And then you treat the other, you know, this, if they're in shock, treat the shock. If they're hypoglycemic, treat the hypoglycemia. If they're seizing and that's their first presentation of the illness, manage that. You know, if they need respiratory support, then you manage that as well. And then we'll just try to draw attention depending on where you're practicing. Obviously, if you're practicing at Mwimbili, it's a tertiary center, you have subspecialists, you have facilities. But if you're at a healthcare center and you know, you just deliver babies and this is the baby that you have, start looking at transferring to a higher level care. The regional hospital, district hospital, Mwimbili if indicated. Before you do that, start the antibiotics on the child. So it's all about preventing progression of infection. And overall, if the baby is stable enough to be treated at your facility, you know, the WHO recommends at least 7 days of antibiotics. If it's meningitis, at least 14 days, depending on how clinical picture is progressing. If, you know, it's if you're going to use gentamicin, which is first line in most babies, ampicillin and gentamicin, then just be aware that gentamicin can be renotoxic and ototoxic. So, you know, watch those kidneys, watch those ears. If you're able to check it trough, check it before the third dose so that you're actually giving a corrected dose. And if possible, do a CRP. And if the CRP and the blood cultures are done and they're negative, you may stop antibiotics after 48 hours. So you don't have to commit antibiotics for the duration, especially, you know, you're ruling out sepsis. You're trying to prevent for progression of sepsis. But if the child is otherwise well appearing, they're feeding, they've progressed fine, and this was their only clinical presentation, 48 hours later, cultures are negative, CRP is low. If you're able to get it, child is feeding well, then you don't have to commit antibiotics for the duration of, you know, whether it's 7 days or 14 days of antibiotics, because then, you know, you change the microbiome of this child and, you know, being judicious with antibiotic stewardship. Can I go to the next slide, please? Does anybody have any comment on that or question before I proceed?
Yeah, I mean, I'll just add what basically you just said about sick infants. So, I mean, sometimes they might just have one symptoms or sign out of those, but the more they add, the more likely the kid is sick or septic. Like if they're in distress or they have multiple episodes of apnea and they're not eating well, pretty much they have sepsis. But if I don't know, 24 hours, they're not just eating well, but everything else is good, then you could do a serial exam. But if they still have, I mean, they told mom had choreo, prolonged rupture, it's better to do blood work and then continue a serial exam before the antibiotics. But if you cannot guarantee to get the blood work, better to do 48 hours of antibiotics than risk baby getting really sick. And then the WHO says 7 days because other areas with a limited resource, they're not able to do a blood culture. So you just go by initial presentation, then you just commit 7 days. But for as Dr. Msambi-Chaka said, if you are able to get blood culture, or if you did a CRP, they're reassuring, the kid in 48 hours turn out, they look great, then you could consider stopping antibiotics to minimize antibiotics exposure to babies.
Is there a question? I heard somebody say something.
No, I was just going to ask, with the antibiotics, is there a period of observation? Because I know Dr. Guido mentioned that there were several, and I think only 2 were mentioned. So is there like a period of observation when to determine whether it's being effective or not? Because I have a friend who suffered really severely from that recently. So.
Yeah, so I mean, the 2 antibiotics, we mentioned that the common ones we use for babies are neonates, and then on the this little box to the bottom left, some of the antibiotics that are used, the ampicillin, gentamicin in the US, Ampiclox, according to Dr. Coney, and then cloxacillin, they're used in Tanzania. So majority of the time, antibiotics, if it were bacterial infection, usual kids or baby, they start getting better in 24, 48 hours if the bacteria is sensitive to the antibiotics. Because that's why when we do a blood culture, we send it for sensitivity. I mean, once in a while, maybe the bacteria is resistant to the antibiotics you're using. So in that case, when you have the sensitivity, then you could switch things around. But these are we call it empiric antibiotics. They're pretty broad coverage. They cover pretty much all organisms. So 48 hours is minimum when you start antibiotics. If you have blood culture that's negative and maybe you're on the fence if it was an infection or not, then you could stop. But again, as I say, sometimes even if they had bacteremia, blood culture might still be negative, but they were infected. So you might prematurely stop antibiotics at 48 hours instead of doing either 7 or 14 days. So it's a whole thing about, we say, like clinical judgment. Look at the patient, look at all the other risk factors, and then decide if it's 48 hours, 5 days, 7 days, or 14 days.
And
Excellent.
Just to add on to that, to add on to that, so with newborns, there's like, certain organisms that most common, as you outlined, group B, strep, E. coli, depending on where the patient lives or the culture stuff, like, listeria. In grown-ups, we've been around surroundings and all that stuff. So the organisms that affect grown-ups might be slightly different, and the resistance to antibiotics. So it's still, like you said, it's the stepwise approach. If they're clinically improving, you're probably treating the right organism. If they're not, within like 48 to 72 hours, they're actually getting worse. You either are missing the diagnosis or you're using the wrong antibiotics. And so you can go to the second line, or like, broaden, as we call it, like start thinking of other things and expanding your antibiotics. But the majority of the time, ampicillin, gentamicin is sufficient.
Asante sana, daktari.
Asante kwa swali.
Anyone else with comments, question on this slide before we move to the next?
Just a quick question. So as a nurse, I see as you were addressing the antibiotics here. So what else should I do as a nurse in conjunction with an antibiotic to take care of this patient who is either suspected of an infection or is experiencing infection?
I think as the nurse, the first thing, the nurses are the ones that are at the bedside. You're the ones that are interacting with the patient. So it's just recognizing infection or recognizing abnormality. I think that's the first step as the nurse. And then alerting somebody that can, come and do like the second line evaluation. But recognizing that this patient is sick, or if you have concerns, and then if they fall into the category where it's like a sick baby, if they are like really sick, you will just know that they are sick and you act on it, get somebody to evaluate the baby and start the appropriate care. But the baby that you're just concerned about that might kind of fall in the yellow zone, as you can see on the early onset sepsis, we don't have any green. Usually most babies are like yellow, and they might go green or they might go red. So if it's a baby that has like, maybe they are feeding poorly and maybe had one low temp, as a nurse, alert somebody, but then do your serial exams. Like this might be a child that you might have to increase vital, monitoring of vitals. You might have to educate the parents to alert you if you have many other patients. And then once, the treatment has started, it's still the same thing. It's just like the constant evaluation and providing feedback to the other healthcare providers, like the doctor or whoever it is, depending on the facility that you're at. Fabian, do you want to add anything else to that?
No, pretty much that. I mean, I agree. The nurses are like in the front line. So usually if you see something and you have concern, just mention it. Because babies, sometimes they'll surprise you. It might be just one episode of apnea, but if you don't do anything else in 18 hours, it might be a different story. So sometimes it's just one episode, don't ignore it. If it's hypoglycemia, they had one and recheck and they continue to have hypoglycemia, maybe there's something brewing. So early intervention is better. So it's babies, if it's a well baby, probably they need to be moved to a different unit with a close monitoring with, I guess, nurse to patient ratio changes, so they can be really watched closely.
Sorry, the last part. Usually we are under the assumption that baby with sepsis or infection or anything is they're going to have a high temperature. And I know you're talking about the 2 months age of the baby. Will always the babies will have high temperature?
In the beginning, most babies have actually low temps. They can have high temps, so fever is not unusual, but the majority of the time, they're not able to regulate. Like when they're sick, they're not able to regulate. Their thermoregulation system is not like, mature enough. And so they might actually drop their temperature instead of having a fever, instead of being like 38 and above. Like if mom had a fever during labor, the baby might come up with like hyperthermia too. But if it's like, 24 hours later and you see a baby that is actually dropping their temps, so 36.5 to 37.5 is what we consider normal, temperature range for newborns. So if this is a kid that's like 36.4, 36.2, and then maybe they go up to 36.5 and then they drop again, that is not normal. It might be normal if you're, this, as Dr. Guido and gave an excellent talk on thermoregulation in newborns last year. You can go listen to that. But, depending on what the environment that we're creating, wet blankets, draft and stuff like that, if you think it's environmental, then you can have an explanation to that. But still, high clinical index of suspicion for infection in newborns that are not transitioning well.
Thank you.
Dr. Sambikat, the next slide.
All right, so the next slide, again, this is you're evaluating a newborn, and this one, we're going up to like 60 days. Again, like I keep emphasizing, these guidelines are in the national guidelines. So we will send a link. It's a lovely 300-page document, but it has a wealth of information. And if anything, you can keep this, like just these algorithms to kind of get your initial assessment going. But I think for much more robust detail, you can refer to the guidelines. So again, you are now, probably this baby has been discharged, and then they're coming to you, whether it's the clinic or it's in the hospital emergency room, and they are, presenting with a problem, whether it's fever, poor feeding, or like tachypnea, or maybe it's just a new mom that doesn't even know what's going on. She's just worried. The first question to ask yourself is, how old is this baby? Are they less than 28 days? Are they less than 29 days, or are they greater than, greater or equal to 29 days? Because that is the fork for your management. And so if your question is, you have a 5-day-old that's coming to clinic, and therefore, the question is, are they less than 28 days? And if the answer is yes, and if they're greater than, 5 days, actually, we would go back to the other slide. So I'll use 8 days. So if they're 8 days old, then if the answer is yes, then you ask yourself, are they sick? Are they looking sick? What's their appearance? Do they have a fever? Are they hypothermic? Are they lethargic, poor feeding? They have all these other associated symptoms. It can be one, it can be multiple of them. Again, it's red. This is a kid that's sick. Do not delay evaluation and treatment. Depending on your facility, again, blood cultures, CBC, CRP, you would add a urinalysis in this age group and obtain a urine culture. If indicated, this is like, if you're able to, but it's definitely recommended that you perform a lumbar puncture. And again, do not delay antibiotics in this age group. And the antibiotics actually easy because they still haven't changed. It's just the frequency that will change. It's still ampicillin, gentamicin. If you suspect that there's maybe like, staphylococcal infection, you can probably broaden it, Ampiclox. I'm not sure how prevalent HSV is in Tanzania, but if you suspect that there's, mom had like history of herpes, or there's actually a family member that has like cold sores, and if you suspect that there's HSV infection, put the kid on acyclovir, monitor for renal toxicity, treat shock if indicated, hypoglycemia, seizures. So the protocol is pretty much the same. The idea is recognize a sick infant, evaluate them immediately, start antibiotics, and then you can do serial follow-ups and tailor treatment as needed. But if you have a child that does not meet this age group, but they're still sick, they have a fever, and maybe they're well appearing on exam. If they have a fever and they're not well appearing, then you go into this next algorithm. It's kind of like a mix, right? You either have, if you're well appearing, fever, but you have these other, if you have a fever and you're not well appearing, that is a child that is sick. And immediately we would move them on the left side of your pathway. And the algorithm is the same. Immediate evaluation, start them on antibiotics, and then continuous clinical evaluation. On the other hand, I think the majority of the kids that we see is like they have a fever and they're well appearing. So the question is, what do you do at that point? Start more like, I think getting a better history and more targeted and focused physical exam is going to guide you. You should, in this age group, urinary tract infections can be the most common, and therefore, check your urinalysis, get a CBC, or like a full blood picture, I believe that's what we call it in Tanzania, and get a CRP if possible. And if they're abnormal, then at that point, you know, send a urine culture if possible, and then you can administer oral antibiotics for at least 7 days. If they have other signs, you know, on physical exam, like they have a soft tissue infection, they have pustules, kind of do more like targeted antibiotic treatment in this age group. But if going to the other side, if they come in, they have a fever, well appearing, and the answer is yes, then, you know, you could check all those things. If they're not abnormal, then, you know, this is a child that you might just do anticipatory guidance. It might be a viral infection, and therefore, you know, educate the family, you know, and reassure them, I don't see any signs of severe disease. You know, this is how, you know, make sure they're hydrated, supportive care if indicated, and most importantly, educate them on when to return, because you might just be catching the child early in their illness course, and therefore they might go home and turn around and actually get sick. But antibiotic stewardship, not every child that has a fever has a severe infection, and therefore it could be viral, and supportive care and monitoring is appropriate. The most important thing is just educating the parents on when to return. Again, on the right side, just want to draw your attention, you know, if you have a sick child, make sure you're referring them urgently to a facility that is able to provide care that you're not able to deliver at your facility. If they're refused or if it's not feasible, you treat what you can in the clinic based on the clinical presentation. You know, if depending on how the child is looking, if they're hypothermic, if they're very young, you know, talk about keeping the child warm. If they're being transferred to the other facility, just knowing that, you know, transportation is different in Tanzania. And then, you know, we talked about this kind of like the guidelines on when to, you know, how the duration of treatment. But most importantly, it's the clinical picture and how they're progressing that will guide your treatment. Any questions about this? Or comments? Anything to add?
Yeah, no, I mean, I think you covered pretty, I guess, extensively. Yeah, I mean, basically, you just have to decide. I mean, the first month of life, we worry a lot. So those are the ones, as Dr. Msambi-Chaka say, you go on the left algorithm on the left side. I mean, you say low threshold and starting antibiotics. After a month, then you decide, are they well appearing if they have a fever, but as we say, I mean, they're smiling, they're playful, they're eating well, and they don't have any other symptoms. You could check basic labs, and then if they look good, just, if possible, just say follow up in 1 to 2 days. And so you can recheck the baby again, make sure they're still doing well. Yeah, Msambi-Chaka saying, and we also talked to Dr. Mkoni, say there's overuse of antibiotics in Tanzania. So our goal is to minimize that, because again, we are creating antibiotic resistance to all this, I mean, basically the whole community. So if they don't need antibiotics, give them a day or two to assess again.
Anybody, any comments? Like, I'm curious, I can't see the people that are in the participant, but I'm curious, is anybody on the group from Tanzania, if you don't mind being brave and just sharing what you've observed or what is being done? Yes.
Yeah, I'm Dr. Albert Chota. I'm working at Dodoma Regional Referral Hospital. So we are having almost the same practice as you rightly presented. So thank you very much for the presentation. We are following the WHO guideline on managing newborn babies, and we have our local guideline which pretty much has the same findings. But I'm very thankful for the algorithm that you presented. In our practice, I think there is an overuse of antibiotics, as you rightly noted. So the algorithm is so good that you differentiate those who are above 28 days, that's 29 days and above, where we need to make some more wake up before prescribing antibiotics. But for those who are neonates, I think within the first 14 days, since we are limited in the laboratory wake up, so we usually give antibiotics, and we most likely start with the ampicillin, gentamicin, or ampiclox and gentamicin. And if there is no any improvement within 72 hours, since most of our cultures are actually negative or we suspect to be contaminants, so we move to our second line, which is cefotaxime and the ampiclox still. And then if there's no improvement, you go to third line, which is ciprofloxacin, and we can go to other more potent antibiotics depending on the clinical presentation. So this presentation helps so much for us to be able to do some more wake-ups on neonates. So thank you very much. We are having a busy neonatal unit here, and we are getting patients from those who are delivered within the hospital, but mothers who deliver at our hospital are those who have been referred from some other centers. So the rate of sepsis is quite high, and the complications are so much happening. And we have babies who come from home after being discharged from several other delivery health facilities, and you have patients who are referred from district hospitals. So they come here with a lot of sepsis. So sepsis is one of the greatest problem we're having here. So thank you very much for bringing this talk. It helps a lot in really trying to sort out this problem. Thank you very much.
Thank you, Dr. Albert Chota. That was very helpful. And that is the one thing we realized is like the guidelines are very comprehensive, but I think digesting them and kind of putting them in algorithm was what was most helpful. And at least for us here in the US, most of our healthcare facilities, as you can tell, we also have like humongous guidelines, but putting a protocol in place helps, especially on a busy day, or, you know, just kind of figuring out like, where does this baby fall and what do I do next? I think it's always very clear when the child is sick, like they are sick in front of you, you know what to do. But when they're kind of sick, but you're not quite sure where, you know, which direction they're going to go, I think this is where we find ourselves overusing antibiotics, when it's really, if we just got a focused history, we might be able to target our treatment much better. And yeah, recognizing that, you know, the diagnostics, the labs and stuff like that might not be readily available on what to do in those instances. Thank you so much.
Thank you. Thank you.
Yes, if I can add, my name is Dr. Moshiro. I'm working at Muhimbili. Yes, we are using more or less this. We are doing more or less the same. But you correctly said, I think tertiary facilities are able to follow the guidelines more or less. But other facilities, the challenge is usually diagnostics. And if the same baby presents, for example, as an outpatient, then that's even more challenging in lower facilities. And that is where the overuse of antibiotics is usually the issue, because somebody is not capable of doing either CBC or CRP, and he has a child with fever. He decides, or maybe this child does not need referral, but you know, but let me give just an antibiotic to cover, you know, if at all it's an infection, and that's usually the issue. But I think for hospitals that are admitting newborns, at least they will be able to do at least a CBC. But it's still usually a challenge if you're starting antibiotics based on high risk of infection, excluding an infection at day 2 or 3, usually it's the most challenging part. For example, if you are starting it based on the risks from the mother's side. So most of the time you end up having those with set risk factors for infection to get antibiotic more than 2 days. That's another issue that usually happens.
Yeah. So for Dr. Mshiri, if I could follow up. So if a child presents in the clinic with fever, do you think there would be a benefit to creating an algorithm for evaluation of fever in the clinic, so that, you know, the healthcare workers feel much more comfortable saying like, yeah, this, you know, it's a fever, child is well appearing, maybe they're not feeling so great, but it might be viral, therefore follow up in 2 days? Or is the fear that the family might not be able to follow up in a couple of days, and therefore you empirically start them on antibiotics just based on those, you know, findings?
It really depends where you are, but I think the most issue is ability of the clinician to exclude and say this is most likely viral. I think you can actually do that using history and clinical examination. But most of the clinicians, and especially general practitioners, it's very difficult for them to exclude. And you know, we do not have pediatricians all over Tanzania.
Yeah.
So most of these child are seen by general practitioners. So you can imagine, you know, for a general practitioner to be able to exclude this is viral because maybe the child started with the flu and there is another person with the flu and fever at home. It's usually difficult for them. So an algorithm definitely could help. So most of the time for pediatricians, they will be able to tease that out and say, no, I don't need an antibiotic here. I just need to follow up this baby in 2 or 3 days.
Okay. Maybe that's something we can try to put together for the clinics and see best, because you know, the guidelines, like I said, are pretty comprehensive. So maybe we can put something together just for the outpatient doctor, or for the lower level healthcare facility. Thank you.
Can I?
Dr. Nido?
Priyanka has a question.
Sure.
Oh no, I wanted to add it for nursing standpoint. You guys put the, you said if the baby is sick, then everybody knows that baby is sick. Those are the ones in between that we need to worry. So as nurses, I think one of the areas then you probably should be focusing on before the antibiotics have been ordered. So there are certain things that you have to do, intervention that you have to do while you're observing that child. So if the child is lethargic and they're not eating very well, probably they're going to be dehydrated. So make sure they have hydration fluids or something, because sometimes they might be just dehydrated, not necessarily that they're going to be septic. But you know, you have to rule out everything else before you assume that, okay, the doctor is going to order the antibiotics. And so when you're calling the doctors and you've seen that child's symptoms, try to have a complete picture. I mean, your vital signs. You are, I mean, we have done A, B, C, D to this child is not working. Maybe probably even check glucose if you have the ability to. So when you're calling the doctors to tell them, okay, this child, I'm concerned about this child, you have some picture to explain, okay, then A, B, and C, and I know the child is not improving. Mom has tried to feed the baby, or baby is throwing up, or whatever. So when the doctor have that clinical, I mean, a complete picture, then there's no delay of care versus you wait until the doctor start telling you, okay, do this, have you done that? And that is also buying them, losing time where the child does not have that much time to lose, especially for the area that is limited. You don't have a lot of resources. So at least as nurses, try to get a bigger clinical picture when you're communicating with the doctors. You have at least, you've already identified areas that the doctor can start working on it, and then they might make the diagnosis faster than waiting for other pertinent information. There's a comment, sorry, there's a comment from the chat. It says, what would you recommend for regional hospitals minimum labs to support maybe diagnosis and management? For health system strengthening, what should the district hospital have as a minimum labs?
So go ahead.
Yeah, so I mean, we talk about the limited resource, and Dr. Moshiro has pointed out, Dr. Choda the same, that I think having algorithm, it helps, especially in some areas with general practitioner. But also, I mean, in basic labs, usually CBC or full blood picture, I mean, it's helpful, but sometimes with the newborn, the numbers might be off and doesn't really help you anything. If you are able to get the inflammatory marker like a CRP, it's helpful. Most likely, if it's elevated, that means it tells your body is fighting infection. And then urinalysis, it's the most common cause for fever in like infants. So be able to run a urine, CBC and CRP are the basics. If the lab is able to do blood culture, for kids who are really sick, because after a month, as Dr. Moshiro said, a good number of kids, they end up having viral illness. So they'll come with a fever, like 39 degrees Celsius, but again, they got runny nose, or several family members have runny nose and stuff. So, I mean, you don't have to do all this workup. So having some sort of like algorithm or guideline to follow, so at least the regional, like, I have this, then do this. I have this, do that. And then just have a way to communicate with the pediatrician. If you have a patient in your office and you are not sure, you call your pediatrician and be like, hey, this is what's going on. What do you think? Then they might be able to guide you and do the appropriate workup.
Yeah, I agree. Like, I think the most like labs sometimes they're helpful when they're abnormal, but the clinical picture. So think of labs as like just one more layer that's going to help you make a decision. You can probably come up with a fair diagnosis just by history and physical exam. Actually, I think studies show like 90% of the time you can come up with a good differential and diagnosis even just based on physical exam and history. And then the lab is like just something else to confirm what your clinical suspicion is. So if you're not able to get any of this, like get a good history. When did all of this start? What does are there any other family members that are sick? Are there any other risk factors that can, contribute to the clinical presentation? Get a good physical exam. Use that stethoscope. I have been to places where somebody does not even listen to the lungs of the kid, and their kid is tachypnic. Well, how are you going to know if they have pneumonia if you don't even listen? And they might have reactive airway disease from a viral illness and not necessarily pneumonia, and that's why they're tachypnic. So I think, but at a minimum, if you're able to get a full blood picture, that's always helpful if it's like abnormal. But know that if it's normal, that should not give you a false sense of security. Like, still look at the whole picture, how the kid's looking, what they're presenting with. And I think that's, Dr. Guido touches on a good point. Like, we at our facilities, if you're not at the tertiary facilities, sometimes our hospitals contract out with like specialists, and then you have like almost like a hotline that you can call. So if I have a child with like a cardiac issue that I feel like it's a little bit outside of my comfort zone, there's a hotline that I can call and speak to a pediatric cardiologist and say, hey, I have this kid, this is my exam, this is my findings, and I am suspicious of this. Can I run the case by you and tell me what you think? And usually, like, it's more like phone a friend, can discuss the case with them and then come up with a plan. And I think the last thing in terms of strengthening the health system is, you yourself, you have to kind of be able to have that knowledge, and then educating the family on when the symptoms worsen, when do they need to seek care. Because I think if you do that, then you might feel comfortable like not starting antibiotics on a child and having them see follow up in 2 days, for example, and then you can reevaluate that patient. And if the kid gets worse in a day, then the family knows to bring them back, so that now at that point you can probably escalate care. I hope that answers your question.
Yes, thank you.
I think in the interest of time, Dr. Guido, can we just skip to the slide on prevention of infection?
Sure.
Or maybe differential.
Differential.
Yeah, we'll
So
send out these slides. Most of the next slides is just kind of just emphasizing the signs and symptoms and evaluation, which we can send out and we already talked about. But I think we can move on to like just the differential.
yeah, so in terms of differentials, we talked about the signs and symptoms for babies we suspected they might be sick. But again, there's some other things that might kind of like mud the picture. So that's when you're gonna have to think and try to tease out and see if you're really dealing with a sepsis or something else. One of them is congenital heart defect. So babies might be born, they'll be tachypnic or they'll be in shock. So again, depending on your capabilities, I mean, Dr. Msambichaka pointed out, physical exam is key. So make sure you listen, make sure you have a stethoscope, you listen. Because most of the kids with congenital heart defect, they will tell you something. Either they have heart murmur, or they might have a gallop, or they might have decreased pulse on postductal area like femoral pulse. So use your physical exam to rule out congenital heart defect. Neonatal encephalopathy from hypoxia again, or metabolic disorder, they can either happen before discharge, or they could come out like 3 days later. So if they have metabolic disorder, they pretty much look like sepsis. Poor perfusion, not eating, very lethargic. Again, you're gonna have to tease out. So that's when you could either do blood work if you can to rule out sepsis. And then, of course, if you are able to do, check for metabolic disorders. Premature infant, also they might have respiratory distress because just the lungs are not mature, so not necessarily sepsis. But again, if you're not sure for premature infant, it's better to do antibiotics for 48 hours and risk missing something serious. Babies who have intraventricular hemorrhage, they might present with apnea, poor feeding, or seizure. So if your baby is 2 days old, they start having symptoms, not necessarily sepsis, it could be they have bleeds in their ventricular space. And then, of course, apnea prematurity. If a baby is born at 28 weeks, they will tend to have apnea prematurity and not necessarily sepsis. But again, if they're born that young, it's probably safer to do antibiotics for at least 48 hours before you could feel comfortable just watching. Hypothyroidism, also they might present with hypotonia, so they might look lethargic. Hyperthyroidism, they will present with either tachypnea, tachycardia, so they might come in looking as if they have infection going on. And then the most common is transient tachypnea of the newborn, where within the first few hours after birth, babies will have respiratory distress. It could be just simple tachypnea, but some of them might have some grunting, retractions, and then most of them resolve within 4 hours to 24 hours. And then meconium aspiration, of course, babies, usually there's a history of meconium fluid. And then hypoglycemia from other causes like SGA babies or LGA babies or infant of a diabetic mother. So presenting with hypoglycemia, they might have tachypnea, they might have apnea, or sometimes just cyanosis. I had a baby who was pretty blue and we did all this. I mean, initial issue like, blood sugar almost undetectable. So it could happen if they just have hypoglycemia, not necessarily sepsis. And then we talk about the antibiotics, first line and the second line, and Dr. Chota also mentioned about third, even fourth line antibiotics. So depending on your level of care you can provide, you might have, but we should try to have at least the first line. You give the dose before you transfer them to higher level of care. So other than talking about management and everything else, but our goal is preventing infection. We can't stress enough about importance of preventing infection on babies because they are high risk for getting severe infection and die pretty quickly. So primary prevention, hand washing. Hand washing saves lives. Just having ability to wash hands, either water and soap or hand sanitizer before you touch the baby. Right before you touch the baby, clean the hands. So wash your hands. Don't touch doorknobs. Don't touch your backpacks, and then go touch the baby. It's like we carry germs everywhere. So make sure we prevent infection this way. So other than early onset sepsis where they acquire from mom, the rest, it's usually either from healthcare person or family member that transmit the infection to babies. Where the capability to screen mom for colonization of group B strep, do that in case you find out they are positive so that you can treat mom before baby is born. If mom has fever during labor, most authorities might consider mom had chorioamnionitis, consider antibiotics for mom to prevent infection on the baby. And then of course, vaccination on the mom, especially for whooping cough. So recommend, like in the US, mom will get the vaccine during pregnancy so baby could get antibodies to prevent infection for the first few months. Minimizing cannula. So if a baby does not need IV fluid, don't put a cannula, don't put an IV. If a baby, because yeah, we're working with some groups about care for babies who are LGL. I guess some places they just go ahead and start start IV fluid if a baby is large for gestational age. So they have to have a reason. If they have hypoglycemia that is not resolving with the feeds, then consider the IV. But otherwise, don't put an IV. And if you're done using IV, please take it out. Secondary prevention, you treat infected mother with penicillin G or ampicillin. And these are moms with a group B strep positive. And then hand hygiene education to the healthcare workers. And then of course, cord care education to the healthcare workers and the parents. And then feeding. So make sure if they're at home, if they are not breastfeeding, if they're using bottles, make sure the bottles are cleaned with clean water, because otherwise the baby might get infected that way. And then use appropriate antibiotics to prevent spread of infection. And then for babies who are born premature and they have or any positive urine culture during pregnancy for mothers, consider doing antibiotics on them. And also treat, the same like the one above, treat women with a fever during labor, regardless of bacterial status. So if you didn't screen, or if their screen is unknown, or it's pending and mom is running a fever, starting treating the mom. And then the antibiotics recommended is ampicillin, penicillin G, and then if they're allergic to those, you might consider cefazolin.
If I could just add on, going back to that slide, I think we cannot overemphasize like a very simple things such as hand hygiene, like for the parents, for the healthcare workers, for anybody around it. And if you're in the United States, putting on your gloves without washing your hands does not count. Wash your hands, put on gloves. So anything that you can do to prevent that lateral transfer, as we talked about, there's, the vertical transmission, which is coming from mom, which is why we're trying to screen for group B strep. I know, I think some facilities in Tanzania are doing this, but not all of them. Hopefully we'll get to a state where the majority will screen for group B strep in mothers. Like the treatment is very basic, penicillin, ampicillin, those are like very readily available drugs. I think we've seen a significant decline in group B strep infections in the United States just because of screening and intrapartum antibiotics, such that now our number one cause of neonatal sepsis is actually E. coli. Group B has been trumped. So hand hygiene for healthcare workers, majitiririka everywhere if possible, so that the families can wash their hands, healthcare workers can wash their hands, and then at home too, just educating the parents. And from a health system standpoint, I think if we're able to figure out how we can make screening for group B strep as part of the care of the mother, I think that will greatly decrease the vertical transmission and decrease the degree of neonatal sepsis that we're currently seeing.
Anyone with the questions or concerns, suggestions?
Well, I would like to thank the both of you for those wonderful presentations. I can definitely say I learned a lot from it.
Thank you.
Thank you.
No, I just want
Anybody else? You
to
can type your question. You can, unmute yourself.
I was just going to add, usually these babies are dependent on the healthcare workers and the parents. So the more education you give the parents and ourselves, the better to help these kids. And for the side of the nurses, I mean, definitely you're on the first line of defense to these babies. So when you see the baby and you are worried about the baby, just get your information on hand, and then we're communicating with the providers, the doctors. Then you can tell them what you see on that baby. And most of the time, as Dr. Msamichaka and Dr. Ngito said, most of the time the babies are not going to show you a full picture. You have to be able to gather the information and then share that information as soon as you can. Don't be afraid and say, look, I'm going to wait until they're round and then I'm going to share the round. The babies don't have the chance. So you need to get your information, as what they said. Do your vital signs, check those lungs, do rule out information, like, make sure the child is hydrated and stuff like that. So if you do those things early on, you're going to help that baby. And if you're not with the baby all the time, then get a family member involved. Educate them signs that they need to look for if the child can't eat and how long do they eat. Because we always just say, we see mom say, oh, I fed the baby for 5 minutes. That's not enough if you're breastfeeding and you're trying to hydrate this baby. So they need to feed a little bit more and observe the feeding and see if really baby's getting enough from there, or maybe baby's just dehydrated and you are trying to jump into baby sick. So
Harriet, you figure out how to send the slides to everyone, and feel free to reach out to us if you have questions.
Yes, if they have their emails, that would be great. I know they was registering, so we get those emails and then send those slides with everybody who attended especially. And then we're going to post the slides on the website, yes.
And the video as well of the presentation will be posted.
Take a look at the, like maybe just a more focused, like health center type algorithm.
Yeah. Yeah. I mean, it would be nice to know what they have or what they can do. So at least when you say, yeah, I recommend this, so at least you know, okay, I have that. But yeah, we'll see what they can do.
We might have to add the nurses' role, like things that they need to be able actually to use, like, the SBAR, these are the things that you need to call the doctor this way and that way. I think that may help to have visual in front of them. So did you do vitals? Did you do the assessment? So at least that things would be like a little checklist before you notify the doctor, so we can have a comprehensive information in front of it. And of course, because some of the nurses are newer, so they might not know the extent of the assessment. So having the, like an algorithm to follow or a checklist to follow in front of them definitely might help them be able to say, okay, did I do vitals? Did I check this, the lungs? Did I do this? The baby's eating? When is the last void? When is the last pee? And those things I think could help. And then at least, especially people who are in the clinical area. I'm sorry, the clinic where there's less resource and less, we don't have the doctor next to you. So you have definitely to call them and yeah.
Yeah, we'll have to lean on you on that one too.
No, okay, so let me put it this way. Let me put it this way. What do you want, if I'm a nurse working with you and then I'm in the unit and you left and there's a delivery waiver. So what did you want from me to make sure I watch and then call you if I need to?
Vitals.
I think it's for the most part, all the vital signs, and then there's signs and symptoms we talked about.
Yeah.
If you have a baby with, I don't know, respiratory distress, I mean, don't wait until I finish my clinic at 5. Just say, hey, come back. If you have a baby with a, I don't know, apnea or whatever, you check your blood sugar is, I don't know, very low, call me. Don't wait until when I come back to the clinic. Don't worry about not bothering me. So, I mean, it's just to empower the nurse, be able to recognize this is not normal. I need, I don't know, second pair of eyes to come and check.
Yeah. Don't tell me.
attending.
Don't tell me you have a baby in distress and you don't give me a respiratory rate.
And then I see them in a, yeah, so to empower. I think
Tell me you have a baby in distress and they're breathing 80 breaths per minute. Like, you got my attention. Like,
exactly.
So I think that would be, you know, or like, and you can even go further and say, I had a baby with a respiratory rate of 80 and I checked the blood sugar and it was this.
Exactly.
Like, go one step further.
Yes, that's what I'm saying. I'm like, if we give them almost like an itemized list of, okay, you know, like you are worried about the baby, did you check A, B, C, D, here, and then notify provider, you know, so I agree with you. Yeah, you don't want to say, oh yeah, the baby's, I can't wake the baby up. Okay, did you check the O2 stat? Oh, let me go check.
Yeah, but I mean, again, those, I mean, for US, I mean, they have protocols. So the nurse know if they have this, do this. If they have that, do this. But so, I mean, like if we do something in Tanzania, they have to know, like, if they're allowed to even do a blood sugar without, I don't know, order, unless it's already a standing order. If the baby has respiratory distress and there's no really good explanation to it, check a blood sugar, because that's the most common cause in, like, in the first few hours of life.
No, definitely, I agree. So to have those, if we give them, like you just identify the algorithm and then having the standing order, like to what extent they can do A, B, C, D. I mean, I agree with you, Dr. Ngida and Dr. Msambichaka, that what we can empower the nurses to do, and then how much they do, and see what is available for them to be able to do that. Ms. Maria Wise, can you speak?
You hear me?
Yes, I can hear you.
Hi, everyone.
Hi.
I love this presentation. And as I'm reading through everything that you all were presenting, it aligns to everything that we pretty much followed in the neonatal intensive care unit in both hospitals that I have worked at. And definitely the algorithm is something that the nurses at the bedside follow, and it's a great guideline for them. As far as the nurses, I like that you're being specific as far as what the nurses are supposed to relate to the physicians. So maternal history absolutely is one on the checklist. Maternal history on the checklist, which was mentioned. Vital signs was mentioned. The quality of respirations is also something, especially if it's respiratory distress. Checking a simple thing like blood sugar and pulse ox, and what are you doing as a nurse at the bedside for intervention at this time to try to help this patient. Poor feeding can be an indicator also of sepsis, is definitely in relation to the vital signs, is something you have to look at to see if it would be sepsis, or it just could be a situation where this is after birth, especially with breastfeeding, and then with those late preterm babies, temperature instability, and we also have to consider, of course, by looking at the baby jaundice. So there's a lot of things on dealing with those little neonates that we have to observe clinically, but vital signs is the most important, especially trending those vital signs. And letting the doctors know within the last 2 hours, this is what we're seeing, or if it is immediate, definitely take a pulse ox and blood sugar and call immediately to let the physicians know, what do we do next? What's our next step? But pretty much what I saw in the algorithm, I love it. It's great. I love that you mentioned changing the gloves. I find that sometimes providers see gloves as protecting themselves, not necessarily protecting the babies. And so with our really small premature babies, so we don't accidentally add another source of infection by accidentally cutting them with our nails or whatever. We have a practice, there was a practice of small micropreemies, wearing gloves whenever you are caring for the babies. There are some not controversy, some discussion on that, but that you want to have that hand touch feel. Yes, I understand that, but the skin to skin contact for hands with the babies once they're stable. But changing out the their gloves as soon as they finish procedure or as soon as they exit out of the incubator is what we like to encourage with our nurses. So anyway, those are the things that I have.
No, that is great. Do you have an algorithm for your nurses, or is it just part of orientation? Because I feel like, you know, there's some things that you just acquire knowledge with time, but then there's other things that I'm not a nurse, so I clearly do not think like one all the time. I try to anticipate what the nurse is going to think, but from a nursing standpoint, especially when you're onboarding like newer nurses, is there like algorithms that you kind of tell them, or is it just like a learned process of saying, well, if you have a baby with respiratory distress or tachypnea, you know, do ABC and let the provider know. I've seen sometimes with newer nurses, they'll be like, oh, baby's tachypnic. Okay, tell me more. Or baby's temp is 36.2. Okay, tell me more.
Mm-hmm.
What was going on? Did the baby have a hat on? Was the baby, you know, was this routine? You're just doing your routine vitals. You went in and swaddled the baby and you checked the temp. That's a very different baby than the baby that was on mom's chest, no hat, no socks, exposed to like the environment.
Every hospital has what we call policy, the different, you know, the different policies or the different guidelines on what to do if a baby's hot, if a baby's cold, and then what are the next steps. We have that in our guidelines, and then at the same time, it is taught by the educators and the nurses at the bedside. What are the next steps?
Okay.
Algorithms are always very, very helpful. We at one hospital had a very specific algorithm when it came to hypothermia and hyperthermia. Is it environmental? Is it your incubator? You know, so there's just a lot of things to consider when you're looking at temperature. But when you're looking at temperature, there's always other symptoms that go along with that if the baby is sick. So you have to closely observe what's going on with the baby.
Okay. Yeah, I think we can.
Sorry, go ahead.
No, I was just saying, I think we can like maybe kind of form like a work group and figure out, I think there'll be two scenarios. There's obviously the NICU babies, and then there's the well babies, and then there's the baby that they're seeing in clinic.
Yeah.
Those are the ones, like I feel like those are the three buckets. I think the NICU most of the time is very well, you know, those people are like even more trained. It's the general practitioners usually, or the nurses that are not like pediatric focused, that are trying to take care of these kids that need the extra help. I mean, we see it here too, like in urgent care, or like, you know, a patient, same child presents to a pediatric ER versus the same child presents to an adult ER. The management and
different.
Workup is very different.
They order everything.
Yeah.
Because beautiful algorithm you presented, definitely we're going to laminate those few of them to be able to take to Tanzania and share with them. So because, I mean, we're all visual, and especially if you're working in a high time, stress time, I don't have time to read the policy like that long. So you just need something, a quick reference so you can have at bedside, and that will help, and compliance is going to be higher. So when they notify the doctors, I think they have more objective data to be able to help them make the different the diagnosis. So okay, thank you, Maria.
Well, thank you guys. I gotta go.
Yes.
Yeah.
Thank you, everyone.
Yes, we share them. Thank you, guys. That was great discussion, and we definitely learned quite a bit.